We will present today our Belgian adventure on the CHIPS, our Belgium National IPC monitoring system. So maybe first as an introduction to get you into the scene of Belgium a little bit. Here you can see we have in Belgium 100 acute care hospitals. So because the monitoring tool we are talking about is about IPC in acute care hospitals. As you can see here, we have 100 hospitals. The half of them have the number of beds is between 200 and 450 beds, so rather smaller hospitals. In terms of IPC, we have a royal decree, so legislation on IPC, what needs to be done, and also on how the IPC teams should look like. There is earmarked funding for the hospitals for IPC. Belgium is a federal state with federated entities, but the weight for the hospital, the competences are mainly on the federal side for hospitals. We have also a federal platform IPC, which I guess you could compare with the national IPC committee. And in there, we have from every province 2 IPC professionals, mostly an IPC physician and an IPC nurse that is represented in there, together with the most important stakeholders. 2 important stakeholders, and definitely for the IPC monitoring system, is the Federal Public Service, in which I'm working as the IPC national focal point, and Sciensano, as you can see here down on the right, which is the Belgian Institute for Health, so the scientific institute. So we also do this presentation together. This was a bit the Belgian scene. The global scene, I think you all know that, but nevertheless, it is worth to precise it. So in terms of the global strategy that the WHO has published a few years ago, very recently, there are 8 strategic directions. And number 5 is exactly what we are talking about today, is data for action. The first indicator in the Global Action Plan and Monitoring Framework that they published alongside the strategy is, you can see here as the first one for the national level for strategic direction data for action, is National Strategic Plan for IPC monitoring should be in place, including an integrated IPC monitoring system for collection, analysis, and feedback of data. So this is exactly the point that we will discuss with you today. And let's go a bit further now into this for monitoring and feedback of IPC in Belgium. We have already a system since 2013. Well, the first data are available since 2013. And it is a mandatory system that every hospital has to report. The indicators that were developed at that time was done also by this federal platform IPC, as I said, like the National IPC Committee. And Sciensano makes hospital feedback reports every year, and also a national report that is publicly transparent. So when you go to the website that I show you down here, you will see the results per hospital with name published. Now, we are more than a decade later, so it was definitely time to give it a reboot. And this is exactly what we did. We started within the federal platform a working group on the indicators. And we said, okay, the priorities in that new set of quality indicators should be obviously informed by surveillance data. So you see here on the right, the results of the ECDC PPS, as you all know, which is the most important or the most prevalent, we all know, healthcare-associated infection is, for example, the non-ventilator healthcare-associated pneumonia. So it was rather clear that those elements should be also included in our new framework. It should also be stepwise improvement model as indicated by the basic requirements by WHO, flexible, obviously, for each hospital context and each hospital priority. And so we did a rapid evidence review on what has to be the key IPC themes included in that framework. It obviously has to be aligned with the IPC core components of the WHO. And on top of that, it should be informed and based on the results that we have last year in 2024 in Belgium, we did perform an evaluation of the IPC program. So let's go a bit to the key IPC themes that we have selected after a rapid review. On the left, it are the IPC themes at bedside that should happen, which is hand hygiene, environmental cleaning, transmission-based precautions and screening, and then all the prevention, the specific prevention measures to prevent CLABSI, CAUTI, VAP, non-ventilator HAP, and surgical site infections. Obviously aligned with core components, which is basically what really needs to be in place in order that these key IPC teams become bedside practice. So I think most probably we all know the core components. You see them here in the circle on the right side, and we try to really integrate them into the new system. As well, as I said, we did an evaluation on the IPC program last year. It was multi-method. And one of the methods we used was a survey that we have sent out to the IPC teams, which has a very high response rate of 87%, with a lot of questions. And one of the questions in the survey was, if you say, so they first had to say which elements are core for their IPC program, and then a follow-up question. If you say it is part of the IPC team activities, does it need to improve in your hospital, yes or no? And you see the top number one of what, according to the teams themselves, needs improvement. You can see here education and training. So that is one thing we take into account. Another method that we've used was interviews. So I did 23 interviews with IPC teams last year. What comes out of that in terms of monitoring and feedback? So obviously most of the hospital and IPC teams, they do perform monitoring, but the care bundles are not routinely already implemented. There are few hospitals with real formal monitoring plans. And feedback is given, but mostly targeted towards the nurses and less to physicians. But then the next points we get a little bit more in trouble is that when indicators underperform, part of the hospital do make action plans, but they don't get consistently implemented in improvement strategies. The plan do checked act cycle is very difficult to complete for several reasons, but this is one thing we really need to take into account. Another result that came out of the interviews in terms of strategic planning is that all hospitals, they do have plans, annual plans, strategic plans, but often when you see how they were constructed, it is very often feasibility driven, like what is possible with the means we have. Also, the use of structural risk assessment is not broadly implemented. And so it means that prioritization becomes based on the last incidents or even external pressure. So these are the things that we try to take into account when we were constructing the CHIPS. And CHIPS, it stands for Check Hospital Infection Prevention Status. So, and this is it. This is the framework of the CHIPS. You see on the right 10 topics, 10 IPC topics with 35 indicators. And every indicator, and every topic has 2 to 4 indicators. So what you see here is the first topic, staffing and enabling environment. Here we ask, we have an indicator to inform us about the IPC staffing in the hospital, about IPC reference, about hospital staffing broadly, so the nurses at bedside actually, and the single patient rooms. Then you have the 8 key IPC topics, as I explained you before, which are the environmental cleaning, the transmission-based precautions, and then the preventions of the healthcare-associated infections. And then the last one is about stakeholder involvement, patient and management involvement. When you see the key IPC topics, the questions we ask is, are your procedures updated and available? Is training and education provided? And is monitoring, surveillance, and feedback activities implemented? Every indicator has a description that says when you score green, yellow, or orange. Of course, the purpose is to get to the green. You cannot do all in 1 year in the hospital. That would not be realistic. So we said, let's aim for that every topic here of these 8 key IPC teams, is green once every 3 years. So more details on this CHIPS framework is, we said it should be adapted to the hospital priorities and the hospital setting. It is why for each IPC team or topic, we ask in advance. Every time we ask, is this topic a priority for your hospital? And then we have several scenarios. For example, it was a priority, but due to unforeseen competing priorities or emergencies, we couldn't work on it, and so on. They can also indicate this is not a priority based on the risk assessment, etc. Why do we say it is also linked with multimodal strategy? It's another core component of of IPC. Is you see here on the left, every time we ask, do you have updated procedures that are available? Do you do training and education? And then they check it. We always check, do they use care bundles? Is there surveillance and feedback? And so on. I've said in the beginning that plan, do, check, act cycle don't get really fulfilled. So that's also why we try to check that part. And how do we do that? Is, for example, plan. It is it will appear if it is in your priority list, yes or no, if it's planned to work on it. The do is obviously all the activities of training and making procedures, etc. The check is the care bundles or the audits or the surveillance. And then act, we will check if results are integrated into an improvement plan, or if they were good, are they documented in the risk assessment? And how do we see that this is really happening? Is by peer-to-peer visits. That goes along with the system. So it is mainly to put horizontal learning in practice, but together with that, it really strengthens the interpretation and the usefulness of the chips, because it gets also a type of validation without that real inspection comes to knock on the door. So it should encourage the open exchange between IPC teams. And so it is now in a test phase, but what is supposed to happen during those visits, we will hear the feedback very soon of the teams that are trying it now, is to really discuss the chips results, also observe where possible, and then obviously the purpose is that the teams that visit each other also exchange the tools of their own hospital. And then we hope that what the hospital would gain in it is that it would confirm their strengths, but it would also help them to identify improvement areas and, of course, give practical ideas and inspiration from their peers. So where are we now in all this process to implement the chips? Here you can see the planning. So we started obviously a little bit earlier than what you see on the slide, but where we are now is that all the participating hospitals in the validation have filled in their questionnaires. We have their results. And now we are here in end of November when the peer-to-peer visits are happening. And all this light green here is what my colleague will explain, is how we are actually validating our tool. So I leave the word now to Sophie, who will go more in depth on how we validate the chips. Sophie, over to you.
Thank you, Anne, and a very good explanation of where we are now. So I'll go a bit more in depth into the validation. And we looked at the feasibility, the validity, the reliability of our system. And we also used the peer-to-peer visits to look at how people are doing in the hospitals. So the feasibility is really looking at the practicality of implementation. How difficult is it for hospital teams to look at this questionnaire and fill it in and get the information and so on. So we had 57 hospitals participating in this validation out of 100 hospitals. So we called it a small survey, but I have no clue why. We called it small. Then we looked into the validity, both construct validity, looking at whether it actually reflects the theoretical concept that it aims to measure. And for that, we did a comparison with the IPCAF survey. 30 hospitals participated in that. We looked also at phase validity. Do we actually measure the intended content? For this, we did interviews with 6 hospitals. For the reliability, we looked at consistency through thinking aloud methodology, observing people filling in the questionnaire from scratch based on the guidance we gave in the CHIPS guide. We did that in 5 hospitals. We also asked for this in the interviews, and then we did the inter-observer reliability, which we measured in 29 hospitals. And then in the peer-to-peer visits, we look at the reports of the visits because we also ask them to discuss if there is a difference between the 2 observers in the hospitals, to document where this difference comes from, also to look at when there is a difference between the result that the hospital gave and that is concluded in the peer-to-peer visit. Why is there this difference? And all of this information is, of course, to improve our CHIPS guide, to make it more accurate in making sure that people understand the same thing and answer in the same direction. Focus group discussions will also be organized for the peer-to-peer visit, but we still have to think about exactly how we will go about that. Next slide, Anne. So we had hospital IPC teams that volunteered to participate. And so we had a questionnaire, and in total we had 86 answers from 57 hospitals out of the 100 acute hospitals in Belgium. And so we gathered our data via Lime survey questionnaires, both for IPCAF and CHIPS. We did on-site thinking aloud visit observations that were recorded and transcribed. In fact, the hospitals that participated in the inter-observer questionnaire also had a 3rd person filling in the questionnaire and being observed during a thinking aloud session. Then we did online interviews per hospitals that were also recorded and will be transcribed. And there we left hospitals the choice whether there was one person that did the interview or whether the whole IPC team wanted to participate. And then we have the peer visitor reports by email. Next slide. So we have some preliminary results, mostly on the quantitative results, because the qualitative ones take a little bit more time to transcribe and analyze. Next slide, please. So user experience, we were very lucky that most of the people did think that our CHIPS questionnaire was or rather useful or very useful. These questions, from what I preliminarily see from qualitative things, is that people are very concerned about getting good results, and that they kind of like go towards a more negative response because they're afraid that they might be considered not good enough, or they don't get the green result every time they want it. Next slide, please. The inter-observer reliability really was to measure the degree of agreement between different individual using the same tool under identical conditions. So we sent a Lyme survey to 2 different people in the hospital, clearly explaining them that they were not supposed to confer, that they had to do this completely independent, no discussions, no sharing answers, and only using the instructions given in the CHIPS guide. And the result we received was, next slide, please, this. With all the white indicating where different answers were given by people. And it looks really patchy and a bit surprising. We thought there would be more harmony in the answers. So next slide, please, Anne. So we looked at it with a more statistical eye. We first looked at the percentage of agreement. It's kind of like what you normally do, how many out of 100% gave the same answer, and should we really be worried. Then we also did coherence kappa, and that indicates how much agreement there is statistically between observers beyond chance. But as we didn't have a lot of answers, and we know that kappa tends to go a bit off the rails if a lot of people give the same answer, we also did a dominance index that showed us when results were really skewed towards one side, because then we knew that the kappa was not really super trustful. And we did this for each topic, for each indicator, and also across the different questions, like all the different procedures, a question that is asked 8 times. We looked at that. And we also looked at the variability per hospital. So we have 35 indicators assessed in 28 hospitals. We lost 2 hospitals, one because it answered too late, and another one didn't really do it independently, but together, so we threw them out. And so we have 980 observer comparisons, and 74.5% showed uniform results, which isn't too bad. It's a moderate level of agreement according to kappa, coherence kappa. Also, what we saw is that there were really outliers in hospitals that really didn't have a lot of inter-observer reliability, while other hospitals had really very good inter-observer reliability. But I mean, most of the people were above 60%, between 60 and 90% agreement. What we did with these results is that for each indicator, we looked at possible reasons for the discrepancy. Where did people not understand our instructions, and what could be possible solutions? And then as a next step, we asked both observers in each hospital to give us as a consolidated answer to do the comparison with the IPCAF, and also to discuss together why their answers were different. And this is something that we will analyze as well. Next slide, please. For the comparison between IPCAF and CHIPS, we were comparing 2 very different things. So what we did is we aligned certain questions of the IPCAF with indicators in the CHIPS. And we have a statistically significant correlation. We did a Spearman rank correlation and a Pearson correlation, and both give us statistically okay correlation for the 2 methods. That the methods, well, when one goes up, the other one goes up, and it's linear as well. What we will do in next steps is we will continue the analysis. For the inter-observer, we will look at the explanations given during the consolidation exercise, and the information gathered will continue to be used to formulate indicator-based hypotheses to guide improvements to our CHIPS guidelines. We will do the same with the information that we get from the transcription, codification, and recording of the recordings, and of both the thinking aloud and the interviews. And all of this information will be transferred to a change logbook of the CHIPS guide, where we kind of like give all the different observations we have, and then we also put in there all the information that we had on questions for clarification and requests for more information. And based on all of this, we will look at each indicator and improve our CHIPS guideline for that. We are also considering training sessions on the CHIPS guide, because during the Thinking Aloud, I saw that people really lead in diagonal version and skip a lot of the information. So we will do a training session. And at the same time, we're also working on a dashboard where the hospitals can look at their own results over the years and filtering for whatever thing they want. We also have benchmarking that happens with hospitals at national level, hospitals of the same size and hospital of the same times, whether university hospitals or non-university hospitals. And then the hospitals will also be able to benchmark their own results against selected hospitals to see where they are, how they compare to other hospitals. And this is more or less what it will look like when comparing at the national level. And that's it from my side. Thank you.
Oops, I was still trying to share the screen, which 1 second, because it stopped. Nevertheless, very important, very last slide, it's the credits. Thank you very much, Sophie. So this is the work that is mainly by the working group of the quality indicators, the federal platform IPC, the federal public service, and Sciensano, with thanks to all participating Belgian hospitals, IPC nurses, physicians, and peer reviewers. So that was our adventure that we are undertaking right now on the Belgian chips. So I think I'll better stop sharing and we can go to any Q&A, if that's fine for the moderator.
Yes, that's exactly the next step. So I don't know if you have question in the audience. If so, please raise your hand or just put a question in the chat. If not, I may have some questions from my side, actually. So first of all, yeah, thank you for this presentation. I think it's a nice mix of an assessment tool and also follow up by well, peer-to-peer activities, which I think has a really important added value, and also the assessment. The assessment part is really impressive, and I think it's really important to be able to learn from an intervention and improve it. So I have a question. So you mentioned that, well, some cheap question in the assessment were aligned and based on the IPCAF, but at the same time in the assessment part, you mentioned that some questions were different. So why did you need to adapt basically the IPCAF tool maybe to your setting? So what was the rationale here?
Mm-hmm. So that's thank you for the question. It's very good to ask that. So the IPCAF tool still remains a very relevant tool to assess IPC in a healthcare facility, and as well the IPCAT on national level. But why did we make an adaptation is because we wanted also to follow up on the IPC key themes. I mean the topics. For example, how do we do on hand hygiene, how we do on environmental cleanliness. And that's something you cannot extract from the IPCAF, because the IPCAF will really assess the core components as a general. They will say, in your institution, do you have guidelines? And then they list all the elements. Do you have training and education? And they will list. So it's a bit, it's very complementary, I believe. Yeah, I don't know if that answers your question.
Yeah, perfectly. And we have a question from Dragomir.
Hi, everyone. Can you hear me?
Yes.
Yes, a really interesting presentation, and these quality indicators are very important. I have two questions. One of them is what is the level of acceptance? I think I speak about the way how the hospitals reacts on that survey, because we have let's say maybe common practices that the hospitals are not so keen to share data, and the other one is what is the possibility to look in your experience to maybe to use some of this in our beginning, because we are planning to do this type of quality indicator and to use it like a pushing, how to say, to stimulating mechanism for the hospitals to share good practices, to implement good practices, and so on. So this is more or less the questions.
Okay. Maybe for your first question was on the acceptance, and
Yes.
I guess the question was also on the public transparency. So here we are lucky because from the beginning, more than 10 years ago, the quality indicators was an initiative already from the National IPC Committee. So really a bottom-up approach. After a few years, they went into this public transparency, which in the beginning was obviously not easy and rather stressful, I think, for the teams. But even there, it was very fastly accepted. It helps also teams because sometimes they think this is their responsibility, but it's not. It's actually the hospital management responsibility to implement a proper IPC. So it gives the leverage also towards the hospital management to say, voila, these are national standards. Please, let's also put the means to comply with them. Of course, we will see now with the new chips, because it gives much more a different information than the old indicators. But I think the field is ready to continue with that. And I'm not sure I understood your second question. It was mainly probably how you're on mute. Dragmi, you're on mute. Can you unmute? Yeah.
This information is available because we can use some, how to say, good practices you have, or the way which the hospitals can be approached in sharing this data. This is a public information, or I saw that there is a website which we can check, like a model, more or less.
Yes, even you can contact us also.
Okay.
We will share for sure every information that is needed or that can be helpful for you also, this presentation. Yeah, so you
Thank
can
you.
definitely reach out to us, no problem.
Thank you. And yes, well, this is also EU-JAMRAI role to help disseminating such example of well, let's say good practices, and to ensure it can inspire other countries. So yes, I really encourage you to reach us or contact Anne if you want further information on this pilot. We also have the Work Package 7 pilot repository on Teams, where you can find also some example of successful pilot on IPC to inspire you. So yeah, please make sure to have bilateral exchange if needed. Yes, Edward?
On this, can I add something maybe?
Yes, Silvana, go
Yes.
ahead.
Because this pilot project repository is Istituto Superiore di Sanità initiative. And as Johan was mentioning, this is also this meeting is the result of a collaboration in presenting pilot projects. And I really do hope that it's going to be also more frequent that other pilots project owners, let's say, they will ask to present in Tuesday Connect because it's very important. I have already one candidate for your session that I suggested previously. I'm waiting your answer. And I think it's very important also to underline that recently I shared also a list of the pilots that we received because this initiative is really streaming the opportunity to benchmark among the countries and the facilities. So I invite everyone that is interested in submitting to us their pilot project to send to me, and I will process it. I will try to add also in the repository. And thank you so much to Anne and to Sophie for this fantastic presentation of today, and see you soon in Rome workshop. Thank you.
Thank you, Silvana. I think we had one comment or question from Edward. So Edward.
Yeah, that's okay if there's still time. Yeah, I think it was a really interesting project and obviously working quite well. I'm just going to have sort of a step back, wider look, question observation, because I was in the EU-JAMRAI meeting a few days ago about the implementation of the EU-JAMRAI principles for AMR. And one of the themes that came out, whether people actually can resonate with these implementations. And I think maybe that's one of the problems you had. How do people interpret what needs to be done? How do they cooperate? How do they take the message away? And I think in the discussion we had last time is that there probably is maybe a little bit of a narrative missing, maybe a more positive health narrative missing, something that makes it more interesting. Because I think if you have a system that only thinks about bacteria, it's a bit dead, really. And I think if you have a narrative that looks more like something to do with health, improving quality of life, and that sort of view, I'm just opening that box rather than giving an answer. But maybe that is something missing somewhere in the work we do in AMR. And maybe, I don't know, does that resonate with what you found out? Maybe.
It definitely resonates. It's definitely still a challenge to really put IPC on the agenda of policymakers and hospital managers. This is a part that we also find out in the evaluation that I think is very okay to share, is that IPC teams in Belgium are very often very independent teams, which is obviously nice because they can do what their priorities are, etc. But then when it comes down to really linking with hospital management, it's obviously a challenge. So it's definitely something we need to explore much further in our IPC bubble. How can we get out of that, and which narrative to use, but also what is really the interest of the hospital managers and on a more national level, IPC policy makers, what talks to them. So it's definitely, we are still on the road to, we have still a margin to explore much better what should happen there.
Mm-hmm. Yeah, I heard the experience of somebody trying in the NHS to make a view, not looked at the patient with their diagnosis, but looked them in their wider context. And she tried to introduce this for 10 years and it just didn't work. The only people who were interested were the nurses. So I think there's a narrative missing in the way how we look at health and disease and everything. And that's just an observation, that's all. Thank you.
I think narrative, but also an integration. We can still integrate better in the other domains of healthcare. So, but yeah, thanks.
I think we are running out of time, but I still have a question. Short question, short answer. But I was wondering how you match people for the peer-to-peer visit. I mean, is it one team visiting all hospital, or do you match teams on I don't know, some specific indicators?
Actually, we asked them. So now we are still in the pilot phase also of the peers to peers, and we have 27 teams participating. Half Dutch, Dutch speaking Flemish, half French. So of course there is already the language barrier, but inside those teams, so during a video call, Teams call, I asked them, how do you want us to organize this? And so we ended up that they all sent me their top 3 or their top 5 of hospitals they want to visit, and then I made the puzzle. So it's not necessarily pairs that one visit and receives from the same. Some are, but some also, it's really based on their own preference. Yeah.
Which is actually good, I think, because that way, well, each hospital has a visit that fit their needs. So sounds great.
Yeah. It's what we try, at least. Yeah.
So thank you for joining today. Thank you, Anne and Sophie, for the excellent presentation. And well, let's meet quite soon.
Thank you very, very much. Have a nice day.